Thank you for kind introduction. I'm Deok Bog Moon. I prepared my presentation as a video clip, including sound, to meet my allotted time. Please start my presentation. Kind introduction. I'll talk about surgical approaches for HCC recurrences at first liver resection. Early HCC is potentially curative, and surgery is the mainstay for the eligible patients. Liver transplant shows 5 to 40% lower recurrence than liver resection, having 50 to 70% recurrence. At our institution, the number of liver resection has been rapidly increasing since 1995, and correspondingly, liver transplantation, including salvage liver transplantation, has also been increased. In regards to repeat liver resection for recurrent HCC patients, the disease-free survival showed similar to primary liver resection. 3-year disease-free survival is almost same, 64.9% and 65% respectively. However, overall survival is lower than primary liver resection. The key prognostic factors are CTP class, that means underlying liver function, and time to recurrence, tumor differentiation, and presence of satellite nodules. When you look into the salvage liver transplantation strategy with the literature overview, post-hepatectomy mortality is from 1% to 9%, and recurrence rate is relatively high, from 27 to 80%. In case of salvage liver transplantation, the indication of liver transplantation should be the same to primary liver transplantation, and the theoretical transplantability was reported to 25 to 83%. However, the actual transplantability after HCC recurrence was less than 50%. Dr. Punja's study was old but important milestone to decide treatment strategy for the small HCC patients with preserved liver function. Cirrhotic patients and oligonodular multiple HCC patients showed inferior survival outcomes to non-cirrhotic chronic hepatitis patients and solitary HCC patients, respectively. In addition, around 80% of Child A small HCC patients are eligible for salvage liver transplantation at time of HCC recurrence. When you look into the benefits between salvage liver transplantation and primary liver transplantation from meta-analysis, the survival outcomes are similar, but bleeding is more common in salvage liver transplantation. From the viewpoint of intention to treat analysis, primary liver transplantation is better than salvage liver transplantation. However, in case of early HCC, although the feasibility of split liver transplantation at liver resection is 34%, the short-term and long-term outcomes of salvage liver transplantation is comparable to primary liver transplantation. Hence, better patient selection for the resection-first approaches and early detection of recurrence is important to improve salvage transplant outcome. Recently published meta-analysis revealed salvage liver transplantation had higher chance of longer operation time, more intraoperative bleeding, reoperation rate, peri-op mortality, post-op bilobascular complications, and recurrence too. However, 1-year overall survival of salvage liver transplantation is similar to primary liver transplantation, and as a result, the surgical outcome is comparable. In terms of oncological outcomes, 3-year and 5-year disease-free survival and overall survival are slightly poorer than primary liver transplantation. From the mentioned result, salvage liver transplant strategy does not seem to be the issue of good or bad, but the issue of availability of living donor at time of treatment. This recent meta-analysis might be helpful for us to decide better treatment for the recurrent HCC patient at primary liver resection. The salvage liver transplant showed better long-term survival than repeated liver resection or curative treatment, including local aberration, additionally such as RFA. From now on, let's look at the experiences of other medical centers. From 1997 to 2015, we had performed 209 salvage liver transplantation and LDLT comprised 91%, minor hepatectomy was 40%, and more than two segmentectomy comprised 60%, and right hepatectomy was the most common type of previous hepatectomy. The right lobe LDLT was the most common, but left lobe or dual graft LDLT also had been performed. This video is salvage LDLT after right hepatectomy. You can see lipidolized S4-HCC. Previous incision was reversed L-shape. A dialysis was performed. From right resection margin, diaphragm was detached. And we can identify suprahepatic IVC. Round ligament was isolated. It can be important role for liver retraction and guide for HALA dissection. Small bowel and colon was detached from resection margin. Bowel was additionally detached from the diaphragm. Diaphragmatic adhesion to hepatic resection margin was released. Cochleization performed to identify vena cava. You can see anterior wall of IVC. Then hepatic hilum was isolated and dissection was performed. Left hepatic artery dissected to second-order branches. Left portal vein was isolated and bile duct was divided. Portal vein was dissected downward to main portal vein. Bleeding control of bile duct stump performed. Caudate mobilized from vena cava. Retrocaval attachment was divided for sound hepatic vein anastomosis. Total hepatectomy was performed. You can see middle and left hepatic vein stump. Then collapsed right upper quadrant space should be expanded for larger graft implantation. Now right hepatic vein new orifice was made from partial excision of IVC wall and fencing with iliac vein. This is the completion view of narrow right hepatic vein. As an engraftment, right hepatic vein was reconstructed. Then portal vein anastomosis was performed. This is the completion view of portal perfusion. Right hepatic artery was reconstructed. Duct-to-duct anastomosis was performed. Follow-up CT scan showed patent vascular structures. This video is the salvage LDLT with IVC replacement. Patient underwent right lobectomy 20 months ago. HCC recurred at caudate lobe close to IVC and hepatic vein. We prepared veno-veno bypass after completion of dissection. This is the completion view. You can see bile duct stump and fully dissected left and middle hepatic artery. En bloc total hepatectomy, including vena cava, was started. Portal vein divided, and bypass catheter was inserted. Suprahepatic IVC was divided. Infrahepatic IVC was divided. Inferior vena cava was replaced by using artificial graft. At the back table, right and middle hepatic vein interposition graft was made into single opening. More than 4 cm sized hepatic vein opening was made. Saphenous vein fencing was performed except some of posterior wall as an engraftment. Large hepatic vein reconstructed easily without risk of tearing due to the kind of cushion effect of saphenous vein fence. Bypass catheter was removed and portal vein anastomosis was performed. Portal vein perfused and air was vented from replaced IVC. Supra and infrahepatic IVC clamping was removed. This is the completion view of portal perfusion. Right hepatic artery reconstructed using left hepatic artery. Due to azotemia, an enhanced follow-up CT scan was performed and no abnormality found. This is 2 left lobe graft using salvage LDLT. 16 months ago, posterior sectionectomy was performed and we could obtain 3 hepatic arteries during operation and successfully perform dual graft LDLT. The 5-year overall and recurrence-free survival was 72% and 83%. Between salvage LDLT and DDLT, the 5-year overall survival of salvage LDLT was significantly better than salvage DDLT, 75% and 42% respectively. Because of the higher chance of early period mortality, 91% and 55% 1-year overall survival respectively. However, 5-year disease-free survival was not so different, 84% and 73% respectively. When you compare to primary liver transplantation, salvage liver transplantation showed poorer overall and disease-free survival outcome. However, if the pre-transplant ACC satisfied ASAN criteria up to 5 cm size and 6 nodules without major vascular invasion, the overall and recurrence-free survival between primary and salvage liver transplantation was not different. 5-year survival after salvage liver transplantation were 80%, 96% respectively. When the tumor was beyond ASAN criteria, salvage liver transplantation showed significantly poorer survival outcome than primary liver transplantation. This is another study undergone propensity score matched comparison from 2005 to 2017 among 474 patients with recurrent ACC after curative resection. There was 163 repeated liver resection and 84 salvage LDLT patients with Child-Pugh A underlying liver function. After the exclusion of the following patients, we performed 1-to-1 propensity score matching, and then there were 42 repeated liver resection and salvage LDLT patients respectively. We performed salvage LDLT when Child-Pugh A patients had recurrent ACC, basically satisfying Milan criteria and located at anatomically unresectable deep sites, and also available living donor is present. But in advanced ACC patients, salvage LDLT was selectively performed in consideration of various factors. When we performed subgroup analysis between salvage LDLT and repeat liver resection, salvage LDLT showed longer operation time and hospital stay, higher chance of interrupt transfusion, particularly large amount of RBC requirement. Post-transplant major complication was significantly higher in salvage LDLT, 53% and 2% respectively. Both overall and recurrence-free survival of salvage LDLT was significantly better than repeated liver resection. 5-year overall survival was 89% and 62%, and 5-year recurrence-free survival was 78% and 28% respectively. When we look into the subgroup analysis in the recurrent patients after salvage LDLT or repeated liver resection, intrahepatic recurrence is more common in repeated liver resection, and both intra and extrahepatic recurrence, including lung and bone metastasis, is more common in salvage LDLT. Around 65 to 67% of the patients were dead after recurrence. In terms of overall survival after recurrence, showed no significant difference in both entire cohort and propensity score matching study. However, there is a tendency of earlier death in salvage LDLT than repeated liver resection. As a summary of this study, repeated liver resection showed higher recurrence rate and subsequently poorer overall survival rate. Salvage LDLT is technically more difficult because it's much more complicated operative procedure under various degree of perihepatic adhesion and distortion of hollow structures. At time of recurrence, salvage LDLT showed higher chance of both intra and extrahepatic recurrences and subsequently tendency of earlier death. This is another study about the outcome of salvage LDLT during 17.5 years after previous major hepatectomy. We performed comparison study between right lobectomy 44 patients and left lobectomy group 30 patients. Right and left trisectionectomy, central bisectionectomy were excluded. As perioperative characteristics, right lobectomy group required hepaticojejunostomy more frequently. Also, operation time is longer and median amount of RBC transfusion is 8 units, much more than left lobectomy group. It's just 0.5 unit. Clavien-Dindo major morbidity occurred more frequently in right lobectomy group. In the presence of severe portal hypertension, salvage LDLT after major hepatectomy must be a complicated operation requiring massive transfusion and special preparation such as veno-venous bypass and all-in-one hepatic vein reconstruction. This patient underwent right and caudate lobectomy 4 years ago, and then TACE, SBRT were performed because of recurrence. Polyp CT scan revealed ascites and well-developed sizable abdominal wall collateral during salvage modified RILOB LDLT, 116 units RBC transfusion, and 42 liters cell-save volume were required. Hospital stay were more than 5 months. The patient is alive without recurrence on post-transplant 64 months CT scan. In terms of technical complications, there were no significance, even though rhinolobectomy group showed slightly higher tendency of biliary stricture, post-bleeding, and obstruction of reconstructed middle hepatic vein. In regards to in-hospital mortality, there was absence in left lobectomy group, but 2 in-hospital mortality cases occurred in right lobectomy group. This patient underwent distal gastrectomy 9 years ago and right lobectomy performed 13 months ago. Salvage LDLT was performed and transfusion volume was not much. However, pancreas injury was suspected during heart dissection. As a result, intra-abdominal bleeding from pseudoaneurysm of common hepatic artery occurred on post-op 8 days, and we performed covered hepatic artery stenting. However, on post-op 16 days, rebleeding occurred from the stump of right hepatic artery and additional hepatic artery stenting was performed. Subsequently, the patient was dead on post-op 30 days from repeated GI bleeding and sepsis. This is the second mortality case. The patient underwent right lobectomy 32 months ago and then TAC was performed. We performed salvage modified right lobe LDLT without interop event. On post-op second day, he suffered from obstruction of middle hepatic vein interposition graft because of limited right up quadrant space after total hepatectomy and also graft displaced towards left side. We performed middle hepatic vein stenting and then liver function normalized. However, general weakness developed. On post-op 15 days, aspiration pneumonia and ARDS occurred and resulted in patient death. Both recurrence-free survival and overall survival after salvage LDLT were not different between left lobectomy and right lobectomy group. As a summary of salvage LDLT after major hepatectomy, salvage LDLT could be safely performed for the patient with recurrence or deteriorated liver function. The mortality after salvage LDLT is mainly related to the technical issues, particularly in right lobectomy group. For good hepatic vein outflows, we should take care of not only bench operation, recipient hepatic vein venoplasty, but also the voluminous reservoir space after total hepatectomy. I would like to conclude my topic as follows. In the absence of living donor, repeated liver resection might be considered for child A up to 5 cm single ACC recurrence patients. However, oncological outcomes of salvage liver transplantation is better than repeated liver resection. When recurrent ACC is satisfying AMC criteria, even after downstaging treatment, salvage liver transplantation showed similar outcomes to primary liver transplantation. In case of salvage LDLT after previous right lobectomy, experienced transplant surgeon is required to reduce the lethal technical complications. Thank you for your kind attention.